Good evening, everyone, and welcome to tonight's webinar brought to you by the Scleral Lens Education Society. So tonight's webinar is called A Toric Update, Staying Ahead of the Curve with Drs. Jedkicka and Morrison. Dr. Jason Jedkicka is an associate professor at Indiana University School of Optometry and the director of the Cornea and Contact Lens Service. He's a diplomate in the American Academy of Optometry's Cornea, Contact Lens, and Refractive Technology section, a past president of the Scleral Lens Education Society, and a fellow and past board member of the Contact Lens Society of America. He's contributed to multiple textbooks as an author on the topic of scleral lenses. He is the developer of the Zen Lens and Zen RC scleral lenses and a consultant to Bausch & Lomb. Dr. Sheila Morrison received her doctorate, master's in vision science, and residency in cornea and contact lenses from Pacific University College of Optometry. She practices at Mission Eye Care Center for Dry Eye and Corneal Disease in Calgary, where she is also a clinical rotation site instructor for University of Waterloo College of Optometry. She has a special interest in her lectures and teaching in the areas of comprehensive ocular surface topography, medically necessary contact lenses, and myopia management. She is a board member of the Cornea and Contact Lens section of the CAO. And with that, I will turn it over to Dr. Morrison.
Well, thank you so much for the kind introduction. We're here tonight to talk a little bit, to give everybody tuned in this evening an update on where we're at with ocular shape, how this applies to specialty contact lens design, and truly the journey we've traveled when it comes to scleral lens design has been an impressive one. You know, we definitely went from not good materials from our early glass blown shells to highly sophisticated materials today. When it comes to shape, what we've actually traveled from is asymmetrical on the left back to asymmetrical on the right. So kind of interesting, as our civilizations tend to do. Sometimes we do return back to versions of things from the past that make sense. So our first design started with this kind of asymmetrical shape, and today we're back to this. Now in between, we have a whole host of designs. So asymmetrical is not best for everybody. There are some patients suited for spherical, toric, quadrant specific, freeform. And so the best way to determine this is to measure it. Ocular surface elevation and shape measurements are essentially kind of the theme of our webinar, and our purpose is, again, just to give you an update of where we're at in these areas. Now, today the breadth of lens design can be a little overwhelming for the average practitioner, even the expert practitioner, because each design and manufacturer tends to use sometimes different characteristics and terminology. I believe the next webinar, which we'll advertise at the very end for you or give you the date, will work to kind of consolidate some of the terminology. But nonetheless, all scleral lenses can be broken down into common zones. They're inclusive an optic zone at the front of the lens. There's an intermediate zone moving from the front to the posterior portion of the lens, a landing haptic zone. Now the landing and haptic zone is the area of a contact lens or the scleral lens that does make up the majority of the contact with the anterior eye. And so this is the most important part that we're seeking to understand when we're looking at the relationship between the sclera and overlying conjunctiva and the contact lens. So why do we care about scleral shape? So when it comes to contact lens fitting, the relationship between that piece of plastic, so the contact lens and the eye shape, may either facilitate success or prohibit it. Now our goals include many things. Certainly we're aiming for comfort, vision, and safety. Now the consequences of decentration can be a big problem when we fit these lenses. So our industry has taken this very seriously with new and current designs available with things like decentered optics. The modifications available today for scleral lenses are vast. So we can put in spherical optics, toric, multifocal, prism. Now, as you see in the photo on the right-hand side, typically we do still see decentration of scleral lenses related to ocular shape. And so because of the shape of the eye being a little bit flatter nasal, steeper temporal, sometimes steeper inferior, plus the weight of the lens itself pulling down with gravity, we tend to have a typical lens that we aim to center scleral lenses. They'll often decenter down and out, leaving us with kind of an offset of the natural pupil location, which is usually superior nasal in most patients. So these are things that affect the optimal, I guess, power of the prism application and also multifocals. Comfort has become a very important part of scleral lens fitting. Today we can do tons of different things. So we can apply microvaults, notches. Our lenses are rotationally symmetrical in spheres. We can apply toric back haptics. Our quadrant-specific lens designs have existed for some time now, and today we're starting to see the freeform design emerge. So we'll talk a little bit more about this today. This is an older photo, just showing, here's an example of a spherical lens on an eye that we've been able to place a notch. And so these types of modifications to lenses that formerly we would do, I remember doing this notch, it was quite a few years ago, by actually drawing on with a Sharpie marker on this lens, having the lab bevel it out. This is completely out of favor with the advent of things like microvaults and digitally measuring the elevations on the eye, because we can actually build in lifts and notches into lenses to fit these types of things a little bit easier from a more scientific approach. Now, today we're definitely in the era of digital lens design. The image you see here is an example of this, and what you're looking at is a fluorescein simulation of a digitally designed lens on an eye, or on eyes that have been mapped with modern Scleral topography technology. And we can embrace this really by imagining things to be very analogous to our historical approach to corneal GP fitting. Now, we have long used an empirical designed corneal GP design sort of philosophy, utilizing corneal topography as kind of the gold standard, where we absolutely need to understand the ocular shape on which we're placing a lens. And so corneal GPs, you'll see that first photo here would be a power map moving into elevation, which is the central picture. And then an empirically designed lens on the bottom right that's based off of the elevation map generated digitally by mapping out the corneal topography of the eye. Now, scleral lenses are certainly no exception. Now, today we use this sort of empirical digital design model to create a similar fitting philosophy where diagnostic lenses still are a path that we can use, but the digital design is a way that we can take an image from a more scientific approach and build lenses based on those things. One thing to remember when we look at corneal GP fitting and scleral fitting, what we're kind of talking about here in terms of designing lenses empirically. So we're using elevation data to create a shape of a lens that suits that patient's eye shape. We're still not replacing at this point the need usually for a GP refraction. So actually identifying the refractive power by placing a lens on the eye. It's on my, I guess, top 10 wish list for the industry. And, you know, we've all been talking about this for quite some time. You know, the future certainly could hold a tool that maybe even could put all of these things into one unit. So we're measuring the shape of the eye, perhaps in the future, and I know that the industry is working towards this, building in things like, you know, A scans and different ways to actually measure the irregular corneal surface and build prescriptions as well. We're not there yet, but that's where we're headed in the future. Now, the next few slides that I have here before moving on for Dr. Jedkicka to go into some of the nitty-gritties of how the technology actually works, I wanted to step back a little bit and just kind of highlight a few of the applications first for big picture for everybody to understand some of the cool things that we're able to do with ocular surface topography. Now, this is an image here. This is a 45-year-old female with dry eye. In the clinic, some of our dry eye patients can be our most sensitive patients. And so small fit misalignments, pressures, little imbalances in the way the lens can sit can be a huge problem for these patients. I know for myself, some of these fits can be a lot more time consuming than many of our medically irregular cornea cases. It always comes down to fit and comfort. And so today with digital guided technology, we can often reach a finish line a little bit faster because the precise measurement first of the ocular surface and then a lens that can be designed based on those measurements often not only has a more successful and kind of faster fitting rate, but it's very impressive for the patient to see this technology as well. And so just setting, you know, that added benefit of having the patient see the technology in your office and have that trust in you that you're have the highest level of technology is wonderful. Now, one thing to mention, we realize that not everybody is going to have a scleral topographer. And so as we move through this lecture and in the coming slides, we're actually going to give you some tips and tricks on how we can utilize ocular shape with or without topography. So the highlight here is ocular surface topography and where are we today? But there's a lot of things that we can do with or without actually having the unit in your practice. And so we'll go through a lot of that as well. Here's another application of scleral topography where we can image and measure elevations and lumps and bumps. We know that when we're placing a contact lens on an eye that has irregularity, it can be extremely difficult to fit a lens comfortably. Now, in this image, this is a very simple concept, big picture where we're able to digitally image a pinguecula that gets in the way of our scleral lens fits. In the center photo, we see an elevation map highlighting that lifted area, and moving to the far right side is a digital wave map that highlights the elevation gains and losses as we travel 360 degrees around at a certain chord where the lens would land. And so as a result is, for example, in this case, we are able to digitally design lenses. Now, in this lens, you can see on the center, based off of these prior elevation maps, the lens was designed with a bit of a notch and a lift, and on the far right, of course, the lens fit looks great. I wouldn't show one on here that didn't in this context, and it certainly did work out great for this patient. Now, moving forward even more, here we are now with the era of freeform lens design. Now, this is just the tip of the iceberg. Here's a patient of Dr. Jenner's that has some irregularity and scarring resulting in a fairly large elevation difference across the cornea. Now that's the bottom portion. So we know that we can typically vault this with the scleral contact lens. However, it can be a little bit difficult if the elevation difference is as great as it is on this eye. And so we have a huge difference, not an easy cornea to fit in the first place. Now on the elevation map, we also see, if you draw your attention to the top right photo, there is a typical sort of red wave that shows the pattern that we would see in a toric or rotationally symmetrical eye. In this patient, their scleral shape is nothing like that. And so typically with, maybe some of our prior designs before the, toric and freeform lens design, this would be a very, very difficult patient to fit, which they were. But utilizing today's freeform design where we can actually digitally image an eye, cornea and sclera, we can also today in 2019 in some designs create what's essentially an eye printed lens digitally. So let's go back to the basics. Now the purpose of those slides is to give you get everybody excited, and we're talking about cool advancements in technology that have allowed us to do things that we never were able to do in the past. Now, back to the basics and to start building our story again, just leading into some of the technicalities that Jason will get into. I already mentioned that not every office is going to have scleral mapping tools. So where do we start, and how do we start to understand scleral shape? How do we use the information that we've been given from our research groups and put this into something practical in the clinic? Now, we can deduce ocular surface shape through diagnostic lenses, and we've got a section to guide you through this. Because this is an art that is absolutely just as much here to stay as digital lens design. It's absolutely essential to understand that the fitting relationship affects the successful outcome. Now, that being said, the overlying conjunctiva can be a little bit forgiving for lens fitting. And so sometimes, keep in mind that while there could be a fit that you see on a patient that generally looks pretty good, the underlying tissue could still be unevenly compressed. And again, that's one of the big advantages of using the scleral topography in the first place, just to get that nice baseline imaging done so that we can be more likely to avoid unequal or unwanted bearing as the lens settles. So our basis for lens design. So we always go back to the beginning of the story. There are several paths for selecting a lens design and fitting starting lens, or selecting what you want to order as far as the shape of the lens goes. So we have the trial and error path, and we also have a diagnostic fitting set path. pardon me, we have our trial and error, and then we have the path of measurement. We're going to talk a little bit here about how do we deduce with sodium fluorescein. Essentially what we're doing is using a known shape lens that is placed on an unknown shape eye and looking at the pattern to deduce or figure out what kind of shape we're dealing with. And from there we could go and modify a lens with or without ocular surface topography in the first place. So a spherical lens placed on the eye that you see here, very tight in the vertical, flapping in the wind on the horizontal. So we could assume here, or we can see quite clearly that this is an against the rule shape sclera that's actually more elevated in the vertical. So up and down, we're closer to the ductor, and on the horizontal, we're further away. So this would require what looks like would be a kind of a toric peripheral design on this lens. Now, Jason, I think you've got a couple other examples. Did you want to pop in now and go through some of the examples that you brought to the table?
Sure, and thank you everyone for being here again tonight. Sheila, could you go back to the previous slide for just a second? I just wanted to make a couple other points. This is a great slide. When you look at the pictures, the montage, the two center pictures of the superior sclera and the inferior sclera, I think it's pretty obvious to see that this is a tight-fitting lens that's bearing in this area a lot. That's easy to spot for even the novice fitter. If you look at the 9 and 3 o'clock meridians, you again can see edge lift. Again, that's pretty easy even for a novice fitter to see that. But what gets to be more difficult sometimes is when you are loose or flat in the vertical meridian. And so we'll go through some examples of how we do that as well. Again, you know, anytime we do a topography, whether it's corneal topography or scleral topography, our maps are presented to us by use of a reference sphere. And so when we look at an elevation map, it's all related to a reference sphere. And our contact lenses can be our reference sphere for our own topography, even if we don't have the instrumentation. So if we have a patient who's got or if we've placed on a patient a spherical haptic scleral lens like we have in this case here, what we can see is in the meridian indicated by the red line, we can see some edge lift down at 4 o'clock in particular and a little bit up at 10 o'clock. And we can then also visualize that at 1 and 7 o'clock, the lens fit is pretty good. So this patient's got a sclera that is steeper in the 10 and 4 o'clock meridian than it is at 1 and 7. Again, what does this tell us? It tells us we need a toric haptic. And so if we have a toric diagnostic lens, great, we can put it on. If we don't, we know that when we need to place that order, we need to be specifying that that 4 and 10 o'clock meridian needs some steepening up to get a better fit. Next slide. Again, a similar look. It's easy to see this flatness at 3 and 9 o'clock, the edge lifting off the eye. You do want to move your light source back and forth carefully to look for this, to try to create that shadowing effect. But in this case, it's pretty clear again that this lens needs to be steepened in the 3 and 9 o'clock meridian to get a better fit, whereas 6 and 12 seems to be adequate as is. So again, our lens working as our reference sphere, showing us the shape of that sclera to be toric.
Jason, when you're evaluating this, do you find it's easiest to look at those flat edges using a little bit of fluorescein externally to see if you can get it to pool, or do you find it's easier for you to see looking with white light in the shadow?
Yeah, I honestly, Sheila, I just usually do white light in the shadow. I'm always moving my light source back and forth, looking at the edges, flipping that light back and forth continuously, even all the way up to about 1 o'clock down to 5 o'clock and 11 to 7. You can usually see a flat edge just by moving that light source looking for shadows.
Okay, great.
Now, what about those instances when you don't see frank shadowing or lifting of the lens or compression? In this case, if we looked at this patient's fit, and you can see that at least 3 and 9 o'clock, it looks reasonably good. If we look at 6 and 12, we're not going to see edge lift, nor are we going to see compression. So if we're just looking for compression or edge lift, this lens should be a good fit. But obviously, as you can see when the patient blinks with the amount of movement, this is not a good fit. And so this vertical movement of a lens with the blink is typical of a patient who has a with the rule toric sclera. the lens is rocking back and forth with the blink across that flat 3 and 9 meridian. So again, vertical movement of a scleral is a good indication that you have a with the rule toric sclera.
Jason, can I divert one more time as well on this
Sure.
topic before we move on?
Absolutely.
You know,
Yeah.
how often do you use, I know we use anterior segment OCT, I know a lot of us out there do. You know, how literally, and I have my own answer to this, but how literally do you take what you see on the edge evaluation with an OCT?
Yeah, gosh, I honestly don't look at edges a lot with an OCT,
Yeah.
and that's not to say that that's the right approach or wrong approach. For me, the time it takes me to walk a patient down to my OCT, capture images, take a look at them more carefully, assess them with a caliper, make measurements. I feel like the more I do, the more I've done this on my own, I can pretty well guesstimate it without having to go to that extent.
You know, and I usually find that the conch can be a little bit misleading at times too, and so sometimes the OCT, it depends, I mean, with a grain of salt. So if you have the imaging with your technicians, great, but yeah, I agree with you. I don't use it as the, you know, the bottom line. The bottom line is our, you know, slit lamp exam, but yeah, just to get your perspective as well.
Yeah, I mean, OCT is great for certain instances. It's very useful if we have it to use it in certain circumstances, but I'm not using it routinely on every patient to assess the edges. So here's another picture which, again, helps us to evaluate that vertical fit. If we look at the picture on the left-hand side, this is just how the lens looks in its natural resting position in primary gaze. And from this, I think we can all see that this lens is decentering inferiorly. Again, when an eye is with the rule toric sclera and that 3 and 9 meridian is elevated relative to 6 and 12, the lens can't stay centered. It's not possible. So it's going to either ride high or ride low. And again, there's really no way a scleral lens is going to ride high. So a lens that rides low, in most cases, is indicative that we, again, have a with the rule scleral shape, and so that when we push this lens up into a centered position, we see that the fluorescein pattern looks better now, it looks more symmetric, but also when we push it up inferiorly, we start to notice the bottom edge of the lens lifting off the eye, indicating again that this lens probably needs to be steepened in the vertical meridian to get it into a better fitting central position.
So, Jason, we can't really talk about, you know, ocular shape without giving, you know, a few minutes to our eye molding. What's in this video is the kind of the freeform eye molding technology, has been around for quite some time. With this technology, the imaging that you see, or in the video, believe it or not, for those that haven't used this before, there's no anesthetic applied to the eye. The eye is very still, and so the feeling of the, you know, cornea being stimulated with pain or discomfort really doesn't happen. And we get a mold of the shape of the eye that is then essentially 3D printed with highly sophisticated layering technology in what is a very, you know, perfectly shaped lens. Now, what we've done with digital technology is essentially move toward this with a digital way. And so the end result, ideally, or what we're aiming to do with the digital technology, the scleral topography, is, you know, ultimately the goal is, you know, similar, where we're seeking to find a way to create lenses that, when we want to fit with an aligned fit, we can do that, even on a very irregular ocular surface. Now, we also have to give homage to our past about where did we start with ocular surface topography. So in 2018, we had our very first published article on the use of anterior segment OCT to map out the eye beyond the limbus. Now, a ton of early work has come out over the past decade from, for example, the team at Pacific University and other academic institutions around the world. Generally, though, in the clinic, we have found that the OCT measurements, you know, I'd say have fallen a little bit out of favor, just because it's a little bit more cumbersome to take, you know, the cross sections and stitch them all together, as we've made way for more current commercially available tools that we use today. Now, the 3 digital scleral mapping instruments on the market that measure topography of the eye beyond the limbus and create the shape of these scleral lenses empirically, we have the SMAP 3D by Precision, a Pentacam Cornea Scleral Profiler, the CSP by Oculus, And then we also have the Eye Surface Profiler by Eaglet Eye. Now, again, as I alluded to before, these instruments don't measure the eye for optics or replace the need in many cases for some type of GP diagnostic lens on to determine power. But again, this will be the way that the future is. Eventually, I would predict that one day we're going to have a tool that can measure the length of the eye, look at refractive power, and do all these things in one unit. Now, because fit and comfort of lenses certainly determines whether or not we can safely and effectively deliver those optics that we're talking about, so our multifocal optics, prism, clear vision, it does make natural sense that we would maybe aim to start to characterize what we can expect in different demographical and refractive profiles. If we could understand and have good population norms related to, maybe refractive error or certain pathology, what eye shape does this type of, patient profile have? This would be definitely an advantage in the realm or in the world of scleral lens fitting. I think Jason's going to head now into some of the nitty-gritties. We're going to get deeper. So we've given you the overview. And now, Jason, would you mind heading into explaining to us exactly how all these technologies work and getting deeper into it for us?
Sure. So just a brief overview of each of these three instruments that Sheila mentioned and how they work. So first of all, we have the SMAP 3D. You can see the instrument on the left and the maps that it generates in an elevation map on the right. Next slide. So the SMAP 3D works by use of sodium fluorescein instilled into the eye, either with some anesthetic or with a lubricant drop to kind of create a more viscous tear layer. The instrument then is aligned in a primary gaze, an up gaze, and a down gaze. So you're going to establish three separate quality scans. The instrument uses a grid that is cast over the eye reflection. So this is a reflection-based system. And because the sclera is relatively matte, it doesn't have much reflectivity like the cornea does. Hence the need for fluorescein and the cobalt blue light reflecting the grid off the eye. Again, you're going to create three separate images of the ocular surface in straight up and down gaze. You're then going to process, stitch, and create a single 3D image of the eye. And again, as you develop an acumen for doing this instrument, how it works, you're going to get really nice three-dimensional, well-stitched, smooth imagery. The three-dimensional image then is used to create a fitted lens to optimize the lens to the shape of the eye. Eye Surface Profiler works in a very similar fashion to the SMAP. You're going to create a 3D look of the eye, but you're going to do it differently with just a single image. So again, it requires the use of sodium fluorescein. It is a reflection-based system. You can see on the image from the instrument reflecting off the ocular surface, that is a grid. Again, it requires that sodium fluorescein because the sclera has very little reflectivity and would be unable to be measured just with straight white light reflection. The images are lined up and image is taken. Typically, even though the Eye Surface Profiler only takes one image to give you a map, we often take multiple images, so we have the option of looking for the highest quality map. And then when we process, we are given, again, a single map that looks like the picture you see here to show us what the shape of the eye is. Next slide. And then the third instrument that you can use in 2019 for imaging the ocular surface, including the scleral shape, is the Pentacam, using its corneal scleral profiling software. So in order to achieve imaging of the entire eye out to 18 millimeters, it requires 5 scans. So when you go to do a Pentacam, you'll get in the main menu, you'll choose the 5 scan CSP option, and then you'll proceed to take a central map, a superior, inferior, nasal, and temporal maps. Each map is done separately. It doesn't require fluorescein because it doesn't work off reflectivity. It actually works off of Scheimpflug imaging. And so what we're given then, again, if you look at the center of this picture where you have a gray, green, purple, red, and blue circle there, this is the data that was obtained by each of your 5 scans and how it contributes to the overall picture. And then the bottom right picture shows us our corneal scleral elevation map, again indicating the shape of the sclera. So all three of these instruments work in slightly different ways, but they're going to give us very comparable maps. And we've studied the outcomes that we get from the three different instruments and how comparable they are. And in terms of measuring like sagittal depth of the ocular surface at any given chord length, they're all really similar and very accurate. And again, when you get a quality image from any of the three instruments, you're going to see a very similar scleral shape. Ultimately, I think where we see differences between one instrument and another is when we're not getting quality scans. So it's really important that we get good images if we want good data. Now, when we get our scleral topography, again, the standard way of looking at scleral topography is using the elevation maps. And so if we're looking at the picture on the right, this is an elevation topography. It's not a curvature map. It's an elevation map. And you have to keep in mind that because the shape of the cornea, the curvature of the cornea, and the curvature of the sclera are quite different, that instead of having a single reference sphere like we would for corneal topography, most of our scleral instrumentation utilizes a separate reference sphere for the cornea and a separate reference sphere for the sclera. And so if you look at the picture here on the map, the central zone within the black ring is all red. And that's because it has its own reference sphere. If we wanted to look at corneal shape, we would choose a corneal shape map instead of a scleral shape map. In this case, what the important point and what we're taking out of this picture on the right is we're looking at scleral elevation, and that's why the scleral zone of this topography has so much more color to it, because that's the area that we're really focusing on. One thing to keep in mind with elevation maps with scleral topography is that blue colors, just like oceanography maps of the oceans, the deeper blues mean deeper or farther away from you as you look at it. And so the steepest part of the scleral shape is actually the area where it's bluer, which is a little bit different than we're used to looking at with corneal topography. So keep in mind that blue areas are farther away from you, which indicates a steeper curvature, and the reds or yellows or the lighter blues indicate closer to you or less curvature or more elevated. So what we can see if we look at these three images in front of you, see three different types of scleral topographies. Looking at the central map, you can see that at a chord of roughly 16 millimeters, or about where the 8 millimeter ring goes around that eye, that this eye is roughly spherical. That same color blue extends throughout most of the map. And so this is a relatively spherical sclera. The picture on the left, you can see a definite elevation area where the eye is more of a bluish green at around axis 60 and 240. And again, this would be the flat meridian of the sclera. And then at axis 150 to 330, in that range, you've got a much bluer scleral map indicating more depressed or steeper. And so this eye is essentially an against the rule oblique-ish scleral shape. And again, a toric haptic would align so that the steeper part of the haptic would be in the blue zone. The picture on the right indicates a with the rule shaped sclera. Again, now our flat meridian is at 150 and 330, and our steep meridian is at 60 and 240. So having the scleral topography, again, you know, if you can use this for lens design, you can make the topographer do the design for you, or you can just simply look at an eye and say, hey, this is what I've got. I've got a toric eye. I need a toric fitting lens. I'm going to grab my diagnostic kit with a toric haptic, and I'm going to put it on, and I'm going to expect to see it orient in such a fashion that my flat meridian of my lens lines up with the flat meridian of my sclera. Next slide. What else can we see with our scleral topography? The picture on the left, you can see a relatively symmetric and spherical shaped sclera from about axis 60, moving counterclockwise around to about axis 340. But here between 60 and 340, we've got a zone of elevation. So this is an eye which is going to be difficult to fit with a spherical or even a toric lens. It would probably be better served with a quadrant-specific design. Again, having the scleral topography, we can see that. The picture on the right shows, again, a relatively spherical sclera with the exception of this focal elevation around axis 350. And what we have here again is a pinguecula, which is creating an area of elevation on the map, which we would either then want to avoid by fitting smaller or somehow notch or vault that pinguecula with an edge modification. Again, all of this is observed through our scleral topography.
Jason, one thing that just comes to mind before we move on from these pictures, you know, you already mentioned it, but just to really emphasize, just like corneal topography, when using it for baseline orthokeratology design or whatever, you know, the quality of the baseline imaging is essential to have accurate data to build from. And so clinically, if you take that extra time to make sure you're getting as much real estate as you can, you'll see on these images, you know, the image on the right looks to be a little bit more of a full kind of picture showing the true scleral shape. The one on the left, there's a little bit of data missing. Definitely still a large enough chord to use for scleral design because the lens will land within that space. But you know, taking the time to get a really high quality image is very, very important with this technology to make sure that you're starting with high quality, not starting with a poor quality image.
Yeah, that's totally right. And you know, I won't lie, the instruments take a little bit of practice to get really good at them. But as you train your technicians and get adept at it yourself and get better and better, the images you can acquire are really fantastic. So I would say to not be discouraged with the learning curve if you do have a topographer, but to just really keep practicing and get good at it makes a difference. What else can we get out of our corneal or our scleral topographer? Our scleral topographers are just loaded with data in them as well, information. And this is just the Pentacam display, but you get this from the other instruments as well. We can see things like the sagittal height at any given chord that's adjustable. We can see the sagittal height in the flat and steep meridians. It can give us our white to white diameter. It can give us the slope of the shape of the sclera in the flat and steep meridians. So again, a wealth of information here that we can obtain to make our fitting process much faster and more efficient. The time you spend obtaining your scleral topography is more than made up for with the efficiency that you gain in fitting the lens more rapidly in the clinical setting.
Jason, how far out can this technology get? So I know I have a pretty good idea of what I can get with most of the mapping tools. I know from what I understand, the current software in the CSP goes out to about maybe 16, extrapolates to 18. For me, that's about what the others are, you know, saying that we can get. What's your experience with the quality further out into the sclera?
Yeah, I think every eye is a little bit different. Some people have easier lids to get out of the way and whatnot. I think if you have a patient who's you're not dealing with a really prominent brow and a tight upper lid, et cetera, if you got a patient who's relatively easy to work with, I feel like with the eye surface profiler, 18 millimeters would be great. I think you can realistically count on 16.5 to 17. With the CSP for the last year or two, it's been rather limited to about 16.5 recently. They've improved the software and now we're getting more like 17 to 18 regularly. And then with the SMAP, because of the stitching process and the way that you can move the eye up and down, you definitely can get further out. You could get, 20 millimeters, in many cases up to 22. Yeah. So it really just depends upon, people ask which of the instruments is best, and it really just depends on what suits your practice. If you want more data, maybe the SMAP is your preferred instrument, but if you want a quicker test that's more efficient, maybe you just want the single scan of the eye surface profiler. If you want an instrument that does a lot of other things, like corneal imaging, posterior cornea, maybe you want a Pentacam. I mean, I think they all are wonderful instruments. They're all just a little different in how they work into a patient or into a doctor's practice. It depends on what the doctor's looking for.
Yeah, I do get asked that a lot as well, and they all have their strengths, right? So yeah, that's a very good point. Yeah.
Just another picture of that focal elevation we showed a moment ago, that pinguecula, and then when you actually have that lens on eye, you can see how that lens compresses that area of focal elevation.
Sure makes the difference to get those lenses designed based off actual quantifying the elevation height. It's a great advantage for sure. So I always think it's important to maintain, kind of coming back to segment 2 of this webinar, it's really important to maintain I would think, a conservative approach with all contact lens fitting within reason. You know, you don't want to be scared. We need to do what we need to do. But we always want to practice from an evidence-based, conscientious, systematic approach with anything that we're doing in healthcare. So where we're at today with technology, it offers us a huge opportunity to be able to just collect more data. So, you know, one particular strategy for fitting lenses is maybe not the buy-all, end-all, but utilizing the technology that we have is certainly, you know, an advantage. Now, we still have more to learn. So in research, the way it works is we usually come up with exponentially more questions for every single question that we're able to actually answer. And one of the examples of that, as I alluded to earlier, is that the research characterizing ocular surface shape really continues, and there's a need for this to continue to expand. Now, dating back over a decade, the Visser group, this is a very commonly cited study that showed clinically some of the things related to patient satisfaction. For example, interviews showed that there were positive differences in terms of how patients were able to comfortably wear scleral lenses with less fogging and greater satisfaction with a toric, a back surface toric design compared to back surface sphere. Again, remember, not every patient needs a toric. Not every patient needs an asymmetrical lens. Some patients do best in a sphere. But again, unless you measure it or pay attention to it, you may miss that. Now, today, dating back from 2017 until now, we're actually starting to see with our technology why some of these things are. So why were they more comfortable? You know, a lens fit that looked pretty similar because that conj is very forgiving. Today now we can see why some of those patients actually did better in a toric design, because if we measure the eye, it's a lot more clear to us that the eye, in a lot of cases, is not symmetrical, and we do need some of these toric and more complex back haptics. Now, this where we moved next was a series of studies looking at modern scleral lens design. So the basis of fitting, in fact, again, is kind of physical structure and optics. I always like to go back to that. As far as the structure goes, what we're actually doing is placing a physical structure, that contact lens, on another physical structure with goals of how we want them to interact. And not everybody fits the same. Some of us like to fit with some tear exchange. Some of us like to fit with a little bit more alignment in most places. But for every practitioner to actually understand kind of what we're dealing with in terms of what is that shape before we place the lens on is a huge advantage. Now, we know that ocular shape is individual. Jason and I had talked about this, whether we needed to even keep this information in here, because it's so commonly cited and so commonly stated, that the eye is like a fingerprint. No two eyes are necessarily alike, and often there are differences between the right and left eye. And we decided, no, this is a point that needs to be hit home over and over and over. Now, the shape beyond the limbus, of course, is where the lens lands. And so that's why we keep on trying to understand it. No, this photo shows a huge difference between the right and left eye in the same patient. So that can be very confusing if you go ahead and just throw, the same lens on a patient right and left design. Maybe you're not expecting to have such an asymmetrical or big difference between the right and left shape. But these are things that we do need to be aware of, because it does exist. Jason, in your experience, I know typically I do find that probably unless there's pathology or unless there's something going on, more patients than not tend to have a little bit more of a kind of near, symmetrical. I guess the right and left eye are somewhat similar, but there is a portion, I would argue maybe even 30% that I would kind of think about in my clinic that certainly have quite big differences between the right and left eye. What do you see in your clinics?
I think you're right on. I think you will see that the majority of patients are going to have relatively comparable scleral shapes, but you're going to get those patients that have, I can think of somebody I know who's got 4 or 5 diopters of regular corneal astigmatism, and in one of those eyes, that cylinder comes right through into the sclera, and the other eye, not at all. It's completely spherical in the scleral zone, just like your picture shows here. So I do think you're right, and I think that's probably right. It's, somewhere in that 25 to 35% of patients will have really different shapes between the two eyes.
These tend to be the ones that you go back and have a bunch of headache with fitting. So sometimes these are the ones where if you don't clue in right away, you can spend a lot of time on refitting and adjusting lenses. And so again, just an advantage of understanding what you're dealing with, because it does vary from patient to patient. You can't always predict it. We hope in the future we can, but our normative databases don't exist yet that way. Now here's a perfect example, getting back to ocular shape characterization. There certainly has been effort to look at the relationship or correlation between the shape of the cornea and the shape of the sclera. Though I will definitely say that our attempts have been very important, the work is very important, but the subject numbers are low and the studies are small. And so here are two studies that essentially have somewhat kind of conflicting data, where one study found that in what they looked at, the scleral shape and corneal toricity not related. Another study looking at things just a little bit differently did see a correlation. Jason, I know that you did a little bit of work in this area as well. So I think I'll have you kind of explain sort of your take on that now.
Sure. So my experience with looking at scleral shape is that there absolutely tends to be a trend towards more of an against the rule shape than the cornea. I don't know what the percentage of real patients that have with the rule cylinder in their cornea versus against the rule. It's probably 9 to 1. Most patients that we see in regular practice, we did corneal topography with the rule astigmatism wins, in a landslide. But as you move out to the sclera and you start looking at scleral shape, I find that against the rule shapes are almost as common as with the rule. And so a few years ago, we did a little study at Indiana where we took patients who all had with the rule corneal topographies, and then we did scleral topography to look and see how they compared. If you look at the black line, that black line would indicate a perfect match between scleral shape and corneal shape. And what you see is the actual outcome is that kind of tan colored line that runs flatter to that. And if you look at the left side of the black line, those are all patients where their scleral topography was more against the rule than their corneal topography. And the dots to the right of the black line, they had more with the rule toricity in their sclera than in their cornea. So overwhelmingly, the cornea tends to be more with the rule than the sclera. That was the point of finding this. And I think that follows through. This is another study that we did looking at keratoconics and normals looking at scleral toricity. I'm going to move to the next slide. And this is a confusing graph, but I'll summarize it for you. If you look at the green section of the grid in the normals, the with the rule patients, starting with the 14 millimeter cord, you see a low amount of with the rule scleral toricity. And as we move out from 14 out to 17, you see that toricity really does not increase at all. If you look, however, at the against the rule group and the oblique group, you see that their cylinder does increase as we move further out across the surface of the eye, indicating that as a rule, if you look at all normals, our cylinder moves more and more against the rule as we move out towards the periphery. That's even more dramatic with keratoconus patients who have increased cylinder in general. In those patients, not only does our with the rule cylinder increase, but our against the rule as well as oblique cylinder increases. But again, against the rule cylinder increases most dramatically. So again, the take home from all this is whether it's a keratoconic or normal eye or any kind of eye, we can generally predict that most scleral shape is going to move more against the rule than the cornea.
Jason, we've had, I know we've both had a fair bit of experience now, analyzing data. It has ranged from looking at, crunching numbers to actually starting to use these scleral shape plots, which have been incredibly useful for actually getting a little bit more of a clear picture that can be analyzed, but also visually sort of appreciated. Would you mind going through these next, actually? So here's kind of the starting point, and I think we have next a few slides showing what a variety of the different kind of scleral shape plots look like, because I can promise you we'll be seeing a lot more of this. If you haven't seen research or seen this being, talked about in lectures, this is one way that we as a standard look at these plots to kind of get an idea of the shape of the eye.
Sure, and if you look at the left side of this picture, this is your scleral topography, and that white ring with the black dots is the sampling of the corneal elevation in that 16 millimeter ring around the sclera. And then what the picture on the right is taking those individual points and plotting them out on a curve to show you the shape of the eye. So we're looking for, mainly with this, we're looking for toricity and we're looking for symmetry. The important thing to keep in mind with these is that your elevation down the left-hand side of your grid may not always be the same. In this case, our scale is about 800 microns from top to bottom of our scale. And so that's important as we look at these to know. In this case, the picture we see shows a fairly symmetric toric pattern with a difference in the peak to trough of around 400 to 450 microns. So that would qualify as an absolutely toric symmetric sclera.
And you know, that peak to trough, another way of kind of understanding, I always think of it as, you know, steep to flat. So the difference between the steepest and flattest points on that eye.
Yeah, so in this case, what I would like to emphasize is these are both pictures of spherical scleras, and they don't look spherical to look at the plot. The point is, again, the scale is very tight on these. And so as we look through, you can see the difference on the left-hand picture. It looks like it's zigzagging everywhere, but it's literally a difference of less than 100 microns all the way around that sclera. So a spherical plots can look very irregular to look at, but again, it's important to note the scale that the plot is drawn upon. In the next case here, again, we see some pictures of what we consider regular toricity, where the peaks and troughs are fairly symmetric for the two. And again, they form what we call a regular toric pattern. Now, most commonly, this is actually the most common finding or type of scleral shape we see is a toric sclera, but where the peaks and troughs don't line up. Either the peaks are different heights or the troughs are different heights. And so these are all examples of asymmetrically toric scleras, where again, something about the eye, something about the shape doesn't line up. Either it's the peaks or the troughs. And then a good percentage of individuals actually have a fairly irregular shaped sclera. Again, thankfully, the sclera is quite forgiving and we can actually work with these patients, but in some cases, if the irregularities are too significant from peak to trough across that shape of the eye, a freeform lens might be useful in these cases. So again, just to break it down into these four different types of groups of scleral shape, we find spherical, toric, asymmetric torics, or just asymmetric irregular shaped eyes. And when we went through and actually quantified the percentages, ironically, only about 6% of eyes were found to be spherical in shape. 28, 29% toric, and then fully 2/3 of patients have some type of irregular pattern, asymmetric toric or irregular. Again, if not for the forgiveness of the shape of the overlying conjunctiva and episclera, most of these patients would be difficult to get a good fit. And it does point to the potential need in the future for more utilization of quadrant-specific and freeform designs as they become available and affordable. So finally, we did another study more recently that looked specifically at the shape of scleras among keratoconic patients. And the one thing that we found was that in the meridian of the apex of the cone, the sclera has the most irregular asymmetric shape. And so that somehow the strength of that corneal surface, the rigidity is lost in the area where the cone is. The effect of that ripples all the way out to the shape of the sclera, so that in general, patients with keratoconus would more often benefit from a quadrant-specific lens design than a normal cornea or a post-surgical cornea.
Jason, you know, on that point, we see this now, you know, and this is actually 2019 study, so I apologize, that's my typo in there, that's just from this year. But what we've seen, you know, where our scleral shape study groups and research groups globally have started very simple. So looking at things like, okay, we've proven now that nasal's flatter. We've proven temporal steeper, all of these things, very simple. What we're starting to see now and what we have a real need for is to further specialize these questions so that they're fit for the populations that we use to fit scleral lenses the most. And so as in this last study, you know, our disease or ectatic population, you know, you will see some of these more specific questions being asked. And, you know, of course, anybody out there that has things to contribute, case reports and things like that, there definitely is a need for it. You know, applying everything into clinical practice is always a challenge in any of our fields of vision care. You know, there's sometimes can be a gap between what we learn in the research communities. Some of us are kind of hybrid between both, and then some of us are very clinical. And so how do you pull that information? You know, one thing that has been very, very helpful for me, and I, you know, certainly would like to recognize our industry and our academic partners for being such supporters of what we do. Use your industry partners and academic partners to your advantage. So, you know, get close with your labs and learn what they're doing. Find out what they're doing to support or what they can do to support you in staying current with what is the latest and greatest. And that will serve you very well. You know, we know that scleral shape is the predictor. So shape is the, you know, ultimately, you know, will allow us to have a stable lens to place the optics. And then what's really exciting about the future is, that I'm really excited about, I know Jason is too, is we can start really focusing on what can we do now with the optics. Once we get a stable, safe lens on every single patient, now what's next with the decentered optics, placing prism, placing, you know, new ways of correcting aberrations and things like that. That's where we're headed next. And so these are really, you know, setting the baseline sort of groundwork of the base has been important, and we need to keep working, but we're moving forward very quickly. So we are definitely in the era of digital lens design. We have instrumentation here now to guide the fitting process and, you know, even design the lenses. This technology is, you know, the new gold standard. It's becoming increasingly more available, but it is not a loss if you don't have every single bell and whistle just yet. Use the tools that you have to use the information to your advantage, because this technology is definitely not going anywhere. It's certainly here to stay.
Yes, so just to wrap up, a couple pearls to take home here before we're done. Lessons learned. Again, as Sheila mentioned before, inter and intraocular differences are common in scleral shape. Torics are more likely to be successful than spherical, as we know that a higher percentage of eyes are toric than spherical shaped. And obviously that's true, as many diagnostic sets are made available in torics. That is a way that some practitioners prefer to go as opposed to spherical. It really just depends upon how you like to work and what you like your lens to tell you from a diagnostic standpoint. Quadrant-specific designs, asymmetrical designs are more likely to be successful. And again, as technology affords us the ability to measure the shape of the eye and actually design these lenses appropriately, I think you'll see that their utilization just gets more with time. And again, toric haptics should be the more common approach to prescribing sclerals over sphericals. If you're prescribing scleral lenses now and you're fitting more of your patients in spherical haptics than torics, you're probably missing out on optimizing the fit more often than not. Scleral shape information, again, keeping in mind the scleral shape tends to be more against the rule than the cornea. Exact correlations are unclear, as we've kind of talked about, but again, a general tendency. Don't assume because the cornea is very toric that the sclera is going to keep that shape through it as well. And the sclera is more spherical. It's also more symmetric as we get closer to the limbus. So when we end up with challenging situations where we just can't seem to get a good fit, remember pulling that lens back a little bit closer to the limbus often can help get the fit finalized. So consider smaller diameter lenses in cases where scleral shape makes it difficult to get a proper fit. And with that, I think
that wraps that up. So, yeah. Thank you so much, Jason, and everybody that's tuned in tonight. I know I really appreciate the time to spend with you. I think Drew probably has a little update here on our next Scleral Lens Education Society webinar.
Yes, thank you very much. It's coming up actually less than a month away. That'll be with Langis Michaud and Mike Lipson. They'll give an update on scleral terminology and just general updates on the modality in general on December 2nd. So please look for emails. As far as this lecture goes, this was eligible for COPE credit 1 hour. There is, because it was a remote lecture, a requirement for a quiz. That quiz does have to have it does have to be graded with a passing score of 7 out of 10. So you'll see an update tomorrow morning, or an email tomorrow morning, with both that quiz and a survey we'd like for you to fill out as well. Please submit those within 2 weeks. That date will be on that email as well. There'll be a copy of this webinar in that email. So if you missed anything or you're not sure of anything, please refer to that webinar. We do have a few questions, if you guys are okay with that, before we log off tonight.
Sure.
This was kind of addressed after this question came in, but just to clarify, basically, given that the minority of scleras are spherical, what percentage would you say you're fitting toric haptics as opposed to spherical haptics?
Yeah, I would say that I'm probably fitting 75% toric haptics and 25%, and it could be a little different one way or the other. Even though only 6% are spherical, another 28% or so are irregular and do not have a toric pattern to them either. And so in those cases, a spherical lens often fits as well as a toric. So again, I think my fitting percentage is pretty comparable to what we found, in that it's probably about 25% of my lens orders are spherical and 75% are toric.
I would throw in quad specific as a portion of the subset of the toric side as well.
Sure.
Yeah, and so there's another question about that. So give us a rough percentage on where that fits in, and how often do you kind of include the idea that those cost more to the practitioner, maybe to the patient as well?
You know, we recently faced that in our practice. I'm back in Canada now, and it is certainly an issue with all of these, you know, the upgrades on the lenses. You know, we still use it quite a bit. To be honest, you know, where we're practicing, I would say probably, I agree with Jason with 25% sphere. I'd say probably another at least 20% is going to be a quad specific for me, maybe more, depending.
Yeah, I think that if I don't have access to scleral topography and I'm fitting diagnostic lenses only, my percentage of quadrant specific is going to be lower, and it's going to be driven by my attempt to fit them without it first and finding that I can't achieve the best fit with a spherical or toric design first. If I have scleral topography and I have that data at my disposal to begin with, and I have certain criteria for what quadrant differences would be worthy of a quadrant specific, I'll go that way right away, or I'll at least explain to the patient the benefit of that right away. And so that there again, we talk about the efficiency that scleral topography can add to your practice. Again, it will immediately tell you whether a quadrant specific design is desirable or not, rather than having to fight through 2 or 3 orders first before you make the discovery, I have to go to quadrant specific.
And then finally, we obviously have spent the majority of the lecture on scleral topography. Is there anything that you use in regards to corneal topography when it comes to fitting, initial lens selection, anything along those lines?
I can certainly comment on that. I think that obviously every lens has its own fitting guide, and you know, following the fitting guide of the recommended lens design you're working with is always the way to go. I do think there's certain things that you can take into account to be better at choosing your diagnostic lens than just straight following the fitting guide, but it has less to do with the keratometry value and more to do with the corneal diameter. I think we missed the boat on HVID all the time. And so if I have a fitting guide that says, you know, if my patient is post LASIK, let's say pick lens number 2, you know, that's great. But if I know that that corneal diameter of that patient is 11.1 millimeters, I'm going to choose a different lens right out of the chute than if that patient's cornea is 12.8. Because again, we know that bigger corneas drive a deeper sag. And so if lens number 2 is what's recommended, if I have a big cornea, I'll pick 3 instead, and if I have a small cornea, I'll pick 1 instead. It makes the process a little quicker. So again, I wouldn't even look at the K readings. I mean, your fitting guide is going to help you with the K reading decision, but what you can do different is you can consider the impact of your corneal diameter on your overall ocular sag.
Thank you both so much. Fantastic lecture as always. Like I said, everybody stay tuned for emails regarding the COPE approval of this lecture and the next lecture on December 2nd. Have a great night, and we'll see you guys next time.